Now, this next panel is near and dear to me, the role of remote monitoring in digital healthcare. My own family took advantage of this technology last year when my dad's heart condition required monitoring. He's there in the red sweater. Instead of being stuck in the hospital hardwired to machines so his doctor could keep an eye on his heart rhythms, my dad was able to go about his daily life, including working while the doctor monitored his heart over a wireless connection. It really was truly amazing. And it was mutually beneficial for the doctor, the hospital, and my father, and I'm pretty sure the insurance company wasn't too upset. I'm happy to say my dad's doing fine now, and we're grateful for the role digital technology played in helping diagnose and get the treatment needed. And he is certainly not alone. There are millions of people out there, many of them older, living with chronic or degenerative conditions such as heart disease, diabetes, Alzheimer's, hypertension, sleep disorders, and many other problems. These new monitoring technologies are really shaping how we and our doctors monitor and manage our health. Sure. So now I'm going to turn it over to the experts. That's okay, our moderator's being mic'd. Our panel is being moderated by journalist Eric Taub. Eric has been writing about the intersection of technology and society, including consumer health technologies, for over 20 years. For the past 17, he has been a regular contributor to the New York Times and was one of the founding writers for the Times Circuits Technology section. If there is any one thing Eric is good at, it is boiling down very complex topics into informative, even entertaining language, so that the average layperson can understand it. And it's clear from his writing over the years that Eric has a real personal interest in where digital health is going. Eric, it's all yours.
Is it on? Okay. Thank you, everyone, and welcome to our panel. This topic became of particular interest to me when, for as long as I can remember, my mother used to say, "Shoot me before you put me into a nursing home." Well, I'm here to tell you we didn't shoot her, but she did go into a nursing home, very much to her regret. It was then, euphemistically called assisted living. She was very unhappy. About a year and a half ago, she died 2 months short of her 101st birthday. And about a few weeks before she died, she said, "You have no idea how decrepit the people are here." So she was there simply for physical reasons. She had trouble walking. She was falling. So we could have kept her in her home, which we tried to do. But the cost of doing that was the same as the $7,000 per month cost in a nursing home. And we were constantly rotating caregivers because people would come that quit after 2 weeks, and they'd spend their entire time watching television in the other room. So they were of very little use. Yet, wouldn't it be great if people were able to live their final days in a surrounding of people of all ages, not just those who are perhaps even more infirm mentally and physically than themselves? But the simple reason we had to bring her into assisted living is because we needed somebody to monitor her drug intake, to make sure that she wasn't falling. She had congestive heart failure, so she has to be weighed daily, if not more than once. And that is also taking the time of the people in the facility. They're spending a lot of time wheeling carts through the rooms, making sure people take their drugs, weighing them all the time. How much money are these facilities spending in labor that could be alleviated if we had a different solution? And I've been speaking to some physicians, and for example, United Healthcare says that because they've started using electronic scales, which convey weight and other information to a website, they've been able to cut down on readmission rates by 25% for congestive heart failure patients. That's very significant. There is a big problem with getting people to take their medications. 1 in 5 people who fill prescriptions never take their drugs. And of those who do take their drugs, 50% of those stop taking their drugs after several months. What if we had a system where we could monitor drug intake remotely, where people could remain in their homes and yet we would still know that they were safe, that they were taking their medications, that they were not gaining weight all of a sudden because of congestive heart failure. And that's what we're here to talk about today. The new systems of remote monitoring that allow that to happen and allow, hopefully, people to remain in their homes in the best environment for their mental and physical health. Dr. S. Vincent Grasso is the Health Information Technology Senior Advisor for the Office of the CTO of Panasonic North America. And Dr. Grasso is a surgeon and a software architect and a medical informaticist. And he's a business analyst with over 15 years of delivering professional services within the international healthcare marketplace. Right now, he's the Health Information Technology Senior Advisor to Panasonic, as I mentioned, and he's also the Chief Medical Officer and the Chief Medical Information Officer with Meadowlands Hospital Medical Center and the Executive Vice President for the Global Healthcare Practice of LGS Global. Dr. Grasso?
Thank you, Eric. Yeah. Yes. I think so. Yeah. Okay. Thank you. Thank you, Eric. No, it's an interesting time. As Eric said, I'm a surgeon, and so I have a very interest in certainly clinical things, and as a software architect, I've always been interested in the digitization of healthcare, which really hasn't happened until recently. I have the privilege to be the Chief Medical Information Officer and Chief Medical Officer of a hospital. I would encourage all of you, if you're being treated in hospitals that don't have a Chief Medical Information Officer, I would use that as a sentiment index of the seriousness of the hospital to move the hospital and its medical staff into a meaningful use environment. So that's an interesting question I would ask the hospitals that you receive care in. This is an interesting time. Eric mentioned some interesting things. Monitoring people at home, remote monitoring of health information is a very interesting and important topic for us that has certain caveats to it that we'll talk about. We've been promoting home monitoring for a long time, but home monitoring is a very interesting and double-edged sword. Sometimes too much information or the wrong kind of information doesn't really help the medical community move the patient along. So I'm going to walk through my deck, and we'll touch on some interesting topics. I'm also in addition to the introduction that Eric made for us, the regional extension centers in the United States are going through their interesting startup phase to implementation phase. I'm the treasurer of the New Jersey Regional Extension Center, and we're entrusted through the Office of the National Coordinator to bring subject matter experts to the doctors in New Jersey to help get them moving from an analog to a digital world. Easier said than done. Certainly will require a lot more money that we've been given, but it's an interesting attempt to try to centralize knowledge transfer from those of us that are interested in this space to the medical community that's primary analog. And again, as a physician, and the physicians that I work with are very nervous, and they're nervous because of this slide. And I don't know if any of you have family members or any physicians in the room, but my uncle was a surgeon, and the surgeons made a different kind of revenue in the 1980s than they did in 2010. So if your medical legal risk goes up and the health cost of healthcare IT goes up and your office overhead goes up, salaries go up, and other related goes up, and revenue over time goes down, that's a very interesting economic model that may not be sustainable for the primary practice solo practitioner. If that's the economic reality of things, well, maybe the delivery model has to change and the business relationships have to change. And again, as a medical informaticist, kind of software guy, I'm always shocked at the interchange of how the community uses four terms: data, information, knowledge, and wisdom. They are not interchangeable. And healthcare, I think, is really the most difficult vertical to work in because many of the algorithms that drive how we care for patients is driven by subjective data. Pain is a subjective qualifier. A heart rate of 120 or a blood pressure of 120 systolic, that's kind of objective. There's not much room for interpretation, but I have pain, I don't feel well, are drivers of what we do. So it's kind of fuzzy in that space. So trying to digitize subjective data and drive algorithms and decision trees is not too easy. But if we mine the data correctly, avoid data bloom, we can have our business analysts help us move some of that data into information